My first lecture for today is going to be on pulmonary embolism, a thing that just won't go away in the emergency department. This issue has been ongoing throughout my whole career of the last 25 years of trying to find that Goldilocks zone. Not over-testing, but not under-testing. The just right testing. And that's what we're going for. And right now, the pendulum has swung all the way over to, oh, you have a chest? Is that discomfort? Is that pain? Oh, we better, do the D-dimer, or let's just go straight to the CTA, right? That's what we're seeing. The pendulum has swung too far towards over-testing. And I've got some abstracts here that will support that position. So the first of the three papers in your manual talks about that right size and how PE is being overlooked for. So abstract number 1, an electronic health record chart review. Okay, so low level of evidence, 2 health systems representing 27 hospitals. So casting the net wide, looking at the patterns around PE testing. So the results, they say in the manual, are a bit startling. I wasn't startled. The diagnostic yield was a single-digit percentage, 3% pickup rate for PE and testing. And so, why am I not surprised? It seems to mirror the ACS literature, especially if you look at North America, in particular here in the US, compared to Europe. When they're doing ACS studies, it's something to keep in mind. The prevalence, how often do they find ACS? And in those studies done in Europe, it's somewhere in the mid-teens, 14, 15, 16% rule-in, right? What's the rule-in rate with your troponins here? 1, 2, 3%, right? Same thing with D-dimers, or same thing with PE rule-in, is around 3%. Now, when they looked at this, roughly 60% of the CTPAs were ordered without getting a D-dimer to rule them out first, using that strategy of saying, hey, if the D-dimer is negative and I've got a low-risk patient, we can be done, right? 60% of the time that wasn't even done, straight to CTPA. And I can't believe that 60% of the people were high risk if they were risk stratified. So it seems that we are over-testing for PE, and that's what the authors conclude, that PE remains a major public health problem of over-testing. Now, abstract number 2 is a chart review studying the D-dimer testing in 3 EDs over a 2-year period. This was done in my province of Ontario. And if I wanted to sell this, I'd say, hey, we're 3 times better because our rule-in rate is 10%. But that's still low, right? It's not the 3% in the previous study, but 10% for ruling in for PE when it's being worked up. But look at it, D-dimers were underused by about 1/3, so 1/3 of the time a D-dimer should have probably been done to rule out and take PE off the table. And when they got the D-dimer, and it was negative, you know what they did? 1 in 5 times? No, I'm not listening. They ignored it. They ignored the D-dimer. Oh, well, it's negative, but I'm going to go ahead. Now, again, clinical judgment, I don't dichotomize and say, well, on one test, and you've got to put it into a clinical picture. Are there cases where I'm concerned and a D-dimer's been ordered, maybe even not by me, right? And it's negative, but I'm like, yeah, we still need to get it, but I can't believe that's 20% of the time that we would overrule that to rule it out. So again, we often are not following sort of a D-dimer to rule out PEs, and even if we do, we often ignore it, like 20% of the time. Abstract number 3 looks at the practice of 77 individual physicians this time at 3 different affiliated institutions and looks at the frequency of utilizing a CTPA by each physician to see how much variability is there, right? And we've got these algorithms now, these algorithms to risk stratify, like Wells criteria has been out for a while, right? The PERC score has been out for a while. Years has been out for, can't help myself, years, dad joke, all right? But it's been out there for a while, and yet the variability is phenomenal. In this study, the ordering, the workup, right, the ordering per amount of overall patient seen, so they not just suspected PE, but how often are these physicians ordering CTPAs? And they did it by 1,000 patients coming through the emergency department. And some ordered as little as 1 per 1,000, and another physician was up at 20 per 1,000, a 20-fold difference. That seems like a lot of variability, doesn't it? All right. Now, you can get critical about the methods within this abstract number 3, and I do like the methods section. It's my favorite section of a paper, looking at the methods section. So you can go, the methods are a bit wonky. But I think the overall theme is, hey, there's a lot of variability, and that I can get on board with and agree with. So the bottom line is PE is over-tested, widespread, it's expensive, it costs money to run these tests, and it opens up patients to potential harm, of course, with all these tests and investigations, and the fact that the D-dimer is underutilized, and even if it is utilized, it's often ignored. And I put an editorial comment in here that, we know knowledge translation takes over 10 years, typically. And so that's what we're seeing with the PE literature. It takes over 10 years till the high-quality, clinically relevant information reaches the patient's bedside, and that's what we're doing. So the next question is the diagnostic approach to PE improved by age adjusting? And the other day I asked, are you adjusting? And you said yes. So that was good news. How about in research, when they actually objectively look at it, not just show of hands kind of thing? Abstract number 4, Canadian research, a convenient sample looking at the impact of D-dimer adjusted cutoffs. And they looked at it over a 2.5-year period. So low-risk patients, if they were low risk, they used a D-dimer was, quote, positive if it was greater than 1,000. Right? Now, if they were intermediate risk, they used the cutoff of 500. Okay, so more conservative. And if they were high-risk patients based on a Wells score, they went straight to CTPA. And they investigated that strategy. And so when they did that, CTA PAs were used less. You didn't get as many CTAs. If you said, listen, if they're low risk, we'll accept 1,000 on the D-dimer, right? If they're intermediate risk, we'll say anything above 500, and we're getting the CTA. And high risk went straight to. And so that decreased the number of CTs using that cutoff, and it was safe. It was safe. They weren't missing a whole bunch of PEs. People weren't dying in Canada because of this adjustment that we know of. Abstract number 5 is some really good community research looking at the impact to try to adjust for age with regards to this. And you guys are familiar with the Kaiser system in California, a big health system that sort of captures their patients. So they do a lot of research there, and a lot of good research, actually. And so they embedded into their electronic record, they labeled D-dimers. They gave the number, but they labeled it either positive or negative. They dichotomized it, but they dichotomized it based on the age. So if you're like me and you're 54, my D-dimer would be 540, right? You just times it by 10. And if I came in at 539, it would say 539, but it would say negative. Get it? Okay, and same thing for every age over 50. So they embedded that right into their EHR to see if they could nudge everybody, right, to not over-investigating. And so, yeah, it worked, but it depends on how you define worked. 3% less CTs were ordered. It went from 36% down to 33%. Yeah, so you could say, ooh, 10%, right, roughly. 10%, that's significant, right? I don't know, but it did nudge the needle a bit. But you know what happened is, this was a before and after study, right? So after, they looked at, well, what happened after? And actually negative, when they were labeled negative D-dimers, the ordering of CTs went up from 6% to 11%. So it just said, yeah, we know we're age adjusting, but I'm just going to get it anyways because it's above 500, right? But the overall number went down a bit. Now, to be fair to this group, though, they were implementing something new in an established practice, and I wonder if they took a look a couple of years later, once people got, okay, I'm more comfortable with, hey, Ken's D-dimer was, 539, we're done. Whereas before, they may have said 539, 540, 54, let's just get the CTA, right? So maybe a couple of years of experience, we would see that number go down. I'd like to see them publish their results later. Abstract number 6, though, is the same experience of an implementation of an age-adjusting strategy, and they saw a 4.4% drop in CTPA use. Now, this was statistically significant, and like I said, it may bear more fruit as people get more used to using this new algorithm or this new protocol of age-adjusting the D-dimer. I asked again the other day, and people said they were doing it. I remember when I first started doing it, I was like, should I do that? But now I'm feeling quite comfortable age-adjusting the D-dimer. Whatever their age is, times by 10, over the age of 50, that's my cutoff, and that's what I use. So bottom line, using an age-adjusted D-dimer strategy, either by clinical risk, so Wells stratification, right? Low, intermediate, or high risk, using a Wells criteria and then the years, or age adjusting is, it can have a moderate impact on how many CTs are being ordered, but it's a safe strategy to use. So should patients, this is the next question, this one was a bit of a shocker to me, should patients being admitted for COPD be screened for PEs? I never did that. I never heard of that until this lecture. I was like, oh crap. Now, like reading the rest of the lecture when I first got it, I was like, have I been doing something wrong for 25 years? You know that feeling, right? It's like, is that what everybody else is doing? So I had never had this sort of idea that, oh, they came in with a COPD exacerbation. Now, if I was concerned that it was a PE, okay, fine, I'm working them up for that. But it wasn't like, hey, you got COPD, you're more short of breath. I've seen you half a dozen times over the last few years for COPD exacerbations. Let's just, make sure it's not a PE. I haven't been screening. Quote, screening is for asymptomatic patients, but these people are short of breath. But they have a good reason to be short of breath. They've got COPD, right? So apparently this is something that had been done. And some research had showed that the number of people who had COPD exacerbations who were screened, 16% of them had PEs. Oh, now I'm really worried. But I got less worried as I got deeper into the literature. So abstract number 7 was an attempt to reevaluate that question. Should we be screening patients with COPD exacerbations for PEs? So they looked at their French healthcare system, and this study was a mandatory. You must screen your PE patients through a pathway for COPD at 7 hospitals over 3 years. And what did they find is that all patients who were screened with COPD using the Geneva score, using a D-dimer pathway for low, moderate, or high risk, so low and moderate got the D-dimer, the high-risk patients went straight to CTA, they found 6% of patients had PEs. Okay, so that's less, that's like 1 in 20. That's less than 16%, so I'm feeling a little bit more reassured. But it's not 0, right? And getting to 0 isn't our goal necessarily, but it's not 0, it's not even close to 0. An interesting part of this study was that clinical gestalt of, hey, do I think they have a PE or not, actually correlated closely to the diagnostic workup and final diagnosis. So it's reassuring that your clinical gestalt, at least if you're a French physician, is pretty good. Abstract number 8, so abstract number 7 said, hey, if you look for PEs, you'll find some, right? Abstract number 8 looks at the question again directly. These are researchers who conducted a randomized control trial screening for PE in COPD patients. And these are patients that are admitted to hospital. And they want to know, does it help if you go looking for PEs? And the answer is no, it doesn't have a patient-oriented outcome. Because if you're screening these PE patients for PEs, for COPD exacerbations without a clear cause, the outcome was the same for finding a PE. It was the same for mortality. It was the same for readmission for virtually every primary and secondary outcome, whether the COPD exacerbation patient was screened for PE or not. Okay? Now, it wasn't 0, though. They did find in the screening arm 0.5% of patients with COPD exacerbations had a PE. I can live with 0.5. I can live with 1 in 200. Now, I don't know about you, in your healthcare system and stuff like that, if 1 in 200 is defendable. But less than 1%, the screening is going to cause more harm than benefit. And now I feel reassured that, oh, okay, good. Phew. The last 25 years, I haven't been practicing incorrectly. So that was reassuring to me. But it also says it doesn't rule it out, right? So, like just because they have a COPD exacerbation doesn't mean they can't have a PE. Yeah, they could. So if you have a clinical concern beyond hey, they're short of breath again. It looks like a COPD exacerbation again. But if you're clinically concerned, then what should you do? Follow your clinical instincts and look for it. But we shouldn't just be doing every single patient routinely who comes in with a COPD exacerbation. That's pushing back on that routine screening. So bottom line, screening for COPD patients can't be recommended looking for occult PEs. It doesn't seem to benefit patients for patient-oriented outcomes like mortality and readmissions. All right, I've tried to avoid teaching about COVID for the last 2 years because I don't know about you guys, but there's just been such a tsunami of information. It's like every single thing has to be COVID. So, hey, this was one little interlude into COVID because it connects to the PE story. And we saw a lot of places getting excited about, do they have a higher risk? Do patients diagnosed with COVID have a higher risk of developing a PE? And can I trust, are my algorithms that we've been using with a D-dimer strategy, risk stratification, age adjusting, is that work in PE patients? And to spill the beans early, yeah, it's just fine. It works. All right? So abstract number 9 is an examination of the D-dimer utility in COVID patients, and it's reassuring. Certainly need a constructed way to approach these patients. It can't just be everybody, right? I mean, they come in short of breath. They've got COVID, right? Their SATs are a little lower. Yeah, it's COVID. They might have some chest pain. Yeah, it's COVID, right? And PEs can present that way, but they have COVID, right? So they looked at a diagnostic accuracy, and that means sensitivity, true positives, specificity, true negatives, of a D-dimer using classic cutoffs, the 500 numbers, right? And they found no statistical difference between patients with COVID, testing positive for COVID, and those who did not test positive for COVID. So the D-dimer by itself, while it's highly non-specific, it's a highly sensitive test, and it appears to work in COVID patients as well. So if you have an outpatient that you're seeing, like so in the emergency department, but you're sending them home, or these are patients that are being admitted, D-dimers should be assumed to have roughly the same diagnostic accuracy. And that's what I'm going to say on COVID. All right. Let's make it a little easier. How about if the patient is pregnant? D-dimers, PEs. Oh, you've got a swollen leg. Yeah, you're pregnant. You're short of breath. Yeah, you're pregnant, right? You might have some shortness of breath on exertion. Your resting heart rate might be a little higher now that you're pregnant. All of these things that change during pregnancy could look like it's suggesting that you have a venous thromboembolism or PE, and sometimes it is. So we've had 2 major efforts over the last few years to look at how can we sort this out in this specific population of pregnant people. So using the Geneva score and an adapted years algorithm. Now these have been validated and have evidence supporting the use to rule out VTE in pregnant patients. Now they try to optimize the sensitivity, that true positive, so you're casting your net wider so you can make sure you get everybody at the expense of specificity. So you will have a low specificity if you do that. And that's because of the integration of the D-dimer, but also because of the clinical risk scores that are involved. And so if you look at abstract number 10, it's the potential future of pregnant patients might be managed using a Geneva score, which has been adapted for pregnant patients. They call it the PAG. And so you can look at that. And they use a heart rate cutoff that's been tailored for pregnancy patients, age cutoff that's been targeted for pregnant patients. And they have these 2 validated approaches. Now, I think that I'm not incorporating this yet into my clinical practice. I think it needs to be validated prospectively, not retrospectively and not in other groups like other institutions, but I would like to see this prospectively validated in another institution prior to me adopting this with my pregnant patients that I'm seeing. So the authors did conclude that this PAG score discriminates risk well and should be tested prospectively. So they agree that it should be tested prospectively before we institute this, or it's not quite ready for prime time. So the bottom line in this section is that testing PE and pregnant patients can be done using the Geneva score or the years algorithm, but the pregnancy-adapted Geneva score may improve this process, but we really do need some more research before we feel quite confident and comfortable using it. And they have that scoring system in your manuals. I'm not going to go through that at this point. All right. What's the current status of outpatient treatment for VTE? So again, this brings up some differences between clinical practices. We have been sending 50% of our PE patients home for decades. Decades. You know, when I first started coming down and teaching and finding out that, 95% of PE patients here are admitted. And I'm like, why? For what? And a lot of it is, originally it was to get them started on Coumadin, right? Get them to therapeutic and bridging them with low molecular weight heparin, giving them injections. How can you do that as an outpatient setting in a system that isn't a system? So I sort of understood that. But now that we have DOACs, now that it's like, okay, here's some pills, right? And you can dry start them. I got that term from Jeff Klein. You don't have to wet start them, meaning you don't have to give them injections of low molecular weight heparin. You can just give them straight on a DOAC, and they're started. You don't have to bridge them, right, like we used to with Coumadin. And so I'm like, well, shouldn't that number come down? And so abstract number 11 is a single-arm study, and it was done by Dr. Jeff Klein, the PE guru, the guy who came up with the PERC rule. So this was his study, and it looked at the importance of how successful this strategy can be, but also how difficult this strategy can be to implement. So what they did was they took clinically stable patients with either a DVT, a PE, or sometimes they had both, right? They had to have low clinical risk scores. So these are well patients. These are not people that are hypoxic, that have all these other comorbidities that you go, yeah, no, they need to stay in, right? We don't have a tube long enough for the oxygen tank, right? So they're staying in, right? But these are low-risk patients, and they put up a clinical pathway into their EHR at 33 centers in the US. And they established that it was both safe and feasible. They got over 1,400 patients into this clinical pathway, and the recurrence of VTEs, because that was one of their outcomes, so they want to look how many people get a VTE even though we're using this, anticoagulation pathway. And the flip side of that is how safe it is, how many people get serious bleeds, right? So VTE recurrence, 1%. Well, that's pretty good. How about bleeds? 0.1%. Oh, that's really good, right? Those are really good numbers. No patients died. Oh, I like that number. Nobody died. Excellent. And adverse events other than that were uncommon. On the other hand, 10% of the PE patients and 18% of the DVT patients at enrolling institutions were enrolled, right, overall. So that's how many people they could capture. But there were some centers that they enrolled a nice round number. So resistance is not futile in some place. Oh, sorry, I'm a huge Star Trek fan. So resistance was not futile, right? They were like, yeah, no, we're not doing that. Even though they put it into these 33 different hospitals, some hospitals are like, yeah, okay, sure, right? And nobody got enrolled. Sorry, something in my eyes, allergies. All right, so abstract number 12 is a database review to support the notion that venous thromboembolism patients can, be treated as outpatients. So this was 61,000 new PE cases were identified, 4% were discharged. Okay, so that means 96% were admitted. And that's where I get my 95%, sort of 95% of PE patients are admitted here. They found that the biggest barrier was hospital and system factors, not necessarily physicians and clinician factors, right? So it was institutional, system, hospital factors. So if you can develop a program that says, listen, I've got a low-risk patient, I know access to medication can be a problem, and access to follow-up can be a problem. So this gets back to evidence-based medicine. The literature can say one thing, but in your clinical environment, you're like, yeah, that's not going to work. I can give them a 2-week starter pack if I have that on some kind of coupon thingy that you guys have, right? And then that's it. They're not going to be taking it for the 3, 6, 12 months that they're supposed to be on it. And by the way, we don't have a thrombotic follow-up clinic that their insurance covers or that they don't have a primary care physician. So I get it. They might need to be admitted, and you might need to bear down, social services and social work to sort those things out that can't be sorted out in that 4 to 6 hour ER visit. And so they might need an admission. So it takes place in a context. I get it. All right. Abstract number 13, comprehensive effort to characterize a prospective studies of patients' management for PEs. So they looked in this study at randomized and non-randomized trials, looking at ED-initiated outpatient PE management. Now, for a quality checklist, they use something called the PRISMA guidelines, and that's what you should do for systematic reviews. The primary outcome was adverse event rates, and this looked pretty good. Short-term mortality, 0.7%. Now, if you looked at the subsection of DOAC studies, though, it was 0%. 0%, nice round number. And recurrence rates for VTE and bleeding rates were both less than 1%. So it looks like it's safe and effective when you mash up this data together, saying, yeah, in a select patient population, you can send them home and reasonably manage as outpatients. Abstract number 14 is in the setting specifically of DOACs. Now this is interesting. You often don't see a head-to-head randomized control trial of 2 competing drugs. And you don't see it here either. This is a database study. Can you imagine, hey, I think our drug's better than their drug. Why don't we do a randomized control trial and find out? Do you think that researcher is going to be in that institution for very long? Right? There's not a big incentive to do that. And so what they did is they looked at insurance database here and said, okay, we've got one DOAC versus the other DOAC. We've got rivaroxaban was prescribed, or we got abixaban was prescribed. And the prescription usually was based on just local cultures and availability, right? One was more a rivaroxaban site, and one was more an abixaban site. And so they did this observational study, and with an observational study, there might be other reasons why the doctor or the clinician picked one versus the other. But it suggested that abixaban had a lower adverse event rate than rivaroxaban. I wouldn't buy into that too much, but they were both equally effective. So yeah, pick a DOAC. You can do this. Outpatient management of VTE. So the bottom line from this section is outpatient PE management when you have a low-risk patient and you wisely select them, safe, effective, and efficient. So some key points and recommendations from this PE lecture are, hey, we're still over-testing. It's a huge problem because our yields are so low. Our diagnostic yields are so low. D-dimer tests are often not done, and even when they are done and found to be low or negative, they're often ignored. Variability between physicians, and Dr. Bucata loves to talk about physician variability. That one study showed a 20-fold difference with regards to ordering CTs. And like in your own practice, right, in your own group, it's usually the nurses that know more. Oh, they're on. The donut's going to be running all day, right? And other ones are, so some people are very test resistant and, they're fine, let them go home, they're fine, right? And other people are on the other end of the spectrum, and it's usually the nurses that recognize this better. Adjusting your D-dimer based on clinical risk or based on their age, great, safe, effective. Patients with COPD, I'm not screening. If you are, you don't need to be, okay? D-dimer testing probably performs similarly in COVID patients. Outpatient treatment for VTE, you can do this. It's safe and effective if you've got a low-risk patient, the right patient, you've carefully selected them, and they have the resources to be managed as outpatients. But it's usually system problems that get to that. Abixaban, this is the last one, may. And anytime you see the word may, and I learned this from Jerry Hoffman, anytime someone says may, you can substitute it with what? May not. Right? May not have less reoccurrence and bleeding, but it's as effective as rivaroxaban.